Imagine a medical condition so structurally devastating that your body's tissue just, well, begins to thin out and bleed.
Right, and eventually even fuse together.
Exactly. Now imagine that up to 35% of the people experiencing this are just told, it is a completely normal part of getting older.
Which is just wild when you actually look at the science.
It really is. So if you are joining us today, you are looking at a stack of clinical studies, medical reviews, and diagnostic guidelines that expose a massive blind spot in postmenopausal health.
And the medical world has a few names for it, like genitourinary syndrome of menopause or vulvovaginal atrophy.
Right. But our mission for this deep dive is highly specific, and honestly, it is a bit intense. We are bypassing that vague idea of just getting older.
Because it is not just getting older.
No, it is not. We want to answer a very precise, objective clinical question today. What exact measurable criteria determine when mild vaginal atrophy crosses that invisible line into severe, irreversible tissue erosion?
The sheer volume of women enduring this in silence frankly, is the real tragedy here.
Yeah, absolutely.
Because if you look at the clinical data we have laid out, patients often dismiss their own symptoms. Society has kind of conditioned them to expect discomfort as they age.
Like they just have to put up with it.
Exactly. But when a clinician looks at this condition, they are not looking for vague discomfort. They are searching for highly specific, objective warning signs.
Like what, specifically?
Well, massive cellular shifts, for one, and the literal evaporation of protective barriers, along with profound structural collapse.
Wow.
Yeah, these are medical red flags that demand immediate intervention, like before the anatomy is permanently altered.
Okay, let's unpack this, because before we can really identify what severe tissue erosion looks like, we have to understand the biological engine that maintains a healthy environment in the first place.
Right, the baseline.
And more importantly, what happens when that engine suddenly loses its power supply? So the sources outline this deeply intricate biological cascade. Pre-menopause, the body is flooded with estrogen.
Very flooded, yeah.
We're looking at baseline peaks during the menstrual cycle of around, I think it was 800 picograms per milliliter.
Yeah, keep that exact number in your head, 800.
Yeah.
Because that abundant estrogen serves as the master biological foreman for the vaginal tissue.
The foreman, I like that.
Yeah, its primary job is to stimulate the vaginal epithelial cells to constantly mature, migrate to the surface, and eventually shed or exfoliate.
So it is like a highly efficient manufacturing line.
Exactly like that. But the most crucial part of this whole process is what happens when those mature superficial cells die and shed. They rupture.
Oh, and they release something. Right.
Yes, they release a massive amount of a complex sugar called glycogen right into the surrounding environment.
And this is where the local microbiome steps in, which is just fascinating. If you are tracking this biological supply chain, that glycogen does not just sit there.
Right, it gets used.
Because a healthy vaginal environment is heavily colonized by protective bacteria called lactobacilli. And these bacteria need a constant food source.
And their absolute favorite meal is that glycogen.
Exactly. So when the lactobacilli consume the glycogen, they produce this crucial byproduct, lactic acid.
And that lactic acid is really the cornerstone of vaginal health.
Yeah.
It drops the local pH into a highly acidic range.
Typically sitting between 3.5 and 4.5, right?
Spot on. And if you understand anything about biology, you know that a pH that low is essentially a toxic wasteland for invasive, harmful bacteria.
So it acts as a shield.
It is an invisible, acidic shield. It prevents chronic inflammation, wards off infections, and chemically supports the elasticity and health of the surrounding mucosal tissue.
Okay, I want to move away from the abstract for a second and give you a mechanical way to visualize this. Don't think of it like a forest. Think of it like a constantly self-renewing brick wall.
Oh, that is a great way to look at it.
Right. Estrogen is the foreman demanding new bricks be pushed to the surface every single day. And as the old bricks fall off, they crumble into dust, which is the glycogen.
I see where you're going with this.
Yeah, and the local cleanup crew, the lactobacilli, they eat that dust and leave behind a protective sealant, the lactic acid, that keeps the whole wall strong and flexible.
That structural analogy works perfectly because during peri and postmenopause, that foreman is abruptly fired.
It's gone.
Gone. The estradiol levels absolutely plummet. Remember those robust peaks of 800 picograms per milliliter?
Yeah.
Well, they drop all the way down to levels below 30 picograms per milliliter.
Going from 800 down to below 30, I mean, the manufacturing line just
The
stops.
entire cellular supply chain completely halts. Without the estrogen signal, the deeper cells just, well, they stop maturing.
So no new bricks are pushed to the surface then.
Exactly. And because the cells aren't maturing and shedding, there is zero glycogen being released. The lactobacilli are deprived of their only food source, so they simply starve to death and vanish from the microbiome.
And without the bacteria, that lactic acid sealant disappears too.
Which fundamentally alters the chemistry of the whole environment. The vaginal pH spikes above 5.0, and in severe cases of atrophy, it actually climbs above 6.1.
Wow, so that protective acidic shield is entirely gone.
Entirely. The tissue is now exposed, vulnerable to inflammation, and becomes completely unable to retain any moisture.
And a doctor looking at this early stage will notice a visible pallor, right? Like the tissue loses its healthy pink hue.
Yes, and there is a distinct thinning of the vaginal lining.
Well, if you are a doctor, knowing that this internal machinery has shut down presents a massive diagnostic challenge. Like, how do you objectively measure the severity of this breakdown?
It is tricky because historically a lot of clinical trials just rely on the symptom approach.
Right. They ask the patient to identify their most bothersome symptom, whether that is dryness or itching or pain during intercourse.
Yeah, the symptom approach is incredibly common. The clinician basically records the patient's subjective experience of pain or irritation and then tracks whether that specific feeling improves over the course of treatment.
It centers on the patient's immediate quality of life.
It does, yeah.
But I have to push back on that approach for our specific mission today, because pain is wildly subjective. You could have two patients with the exact same structural damage, but one reports mild discomfort while the other is in agonizing pain.
That happens all the time in clinical practice.
Right, so how does a doctor actually look past the subjective feelings and see the physical difference between mild thinning and profound tissue breakdown?
What's fascinating here is that relying purely on subjective pain scales completely obscures the physical reality of the damage. Clinicians and researchers recognize this massive gap, which is what led to the development of strict objective scoring systems.
Okay, so they needed a metric.
Exactly. The most critical one outlined in our stack of sources is the Visual Health Index, which was originally developed by Dr. Gloria Bachman.
Bachman's scale, right.
Yeah, it completely removes the guesswork and forces the clinician to formally grade the physical architecture of the tissue.
I'm looking at the criteria for this visual index right now, and it grades 5 very specific parameters during a physical exam. Each parameter gets a score from 1 to 5.
With a 5 meaning excellent, robust tissue.
And a 1 meaning severe abnormal atrophy. So the total possible score is 25. And if a patient scores below 15, they are objectively diagnosed with atrophy.
Right, and those 5 parameters are elasticity, fluid volume, pH, epithelial integrity, and moisture.
So taking them one by one reveals exactly how the tissue degrades. We already discussed pH, which measures that chemical shift away from acidity.
And fluid volume and moisture evaluate the literal hydration of the tissue, which, as we know, evaporates when that cellular supply chain halts.
But elasticity and epithelial integrity, I mean, that is where we really start to see the physical architecture crumbling, isn't it?
Oh, absolutely. Elasticity measures the tissue's ability to stretch and return to form, and that relies entirely on deep collagen fibers that estrogen normally maintains.
And epithelial integrity is essentially checking the durability of the outer layer. Basically, how easily does this wall crumble when you actually touch it?
Exactly. But the visual index isn't the only tool they have. To definitively prove that the estrogen foreman has abandoned the factory, doctors also use a cellular index.
Okay, how does that work?
They take a physical swab of the cells directly from the lateral upper vaginal walls and place them under a microscope.
They are looking for a specific cellular ratio here, right, between superficial cells and parabasal cells.
They are, yeah. In a healthy patient, the microscope slide is packed with mature superficial cells. You know, the ones that are supposed to shed and release glycogen.
But when estrogen plummets, the tissue is physically stunted.
Right. It completely stops producing those mature outer layers. So under the microscope, severely atrophic tissue is dominated by what we call parabasal cells.
Wait, what exactly is a parabasal cell, and why is seeing them a red flag?
So parabasal cells are deep, immature cells. They're supposed to stay buried near the base of the tissue layer, acting as the foundation.
Oh, I see.
Exactly. So if a clinician swabs the very surface of the vaginal wall and finds a slide completely dominated by these immature parabasal cells, it means the entire top layer of the tissue has just eroded away.
Meaning the protective barrier is completely gone.
Exactly. The foundation is fully exposed to the surface. It is an undeniable microscopic marker of profound estrogen deprivation.
Here's where it gets really interesting because we finally have the tools to answer the core question of this deep dive.
Right, the threshold.
Yes, we know a visual index score of 5 is a healthy, acidic, elastic environment dominated by mature cells. But what is the strict clinical definition of severe tissue erosion? Like, what does a score of 1 actually look like?
Honestly, a score of 1 represents total architectural failure. When those 5 parameters of the visual index bottom out, the physical transformation is staggering.
Let's use another structural analogy to picture this.
Uh-huh.
Think of the walls of a healthy, estrogen-rich vagina like a well-oiled accordion.
A well-oiled accordion, okay?
Yeah, it is incredibly elastic and full of natural, deep folds and ridges that allow it to expand, stretch, and accommodate without tearing.
Right, and in medical terms, those folds are called rugae. They're the structural mechanism that allows the tissue to be distensible.
So when a patient crosses the threshold into severe end-stage erosion, what actually happens to the accordion?
The accordion goes completely flat.
Wow.
Completely flat. The definitive clinical sign of severe progression is the absolute obliteration of the rugae. The vaginal wall becomes entirely smooth, rigid, and often has this glazed appearance. It loses 100% of its natural ability to expand.
That is terrifying. And the sources also note a massive shift in color. A score of 5 is that robust, healthy pink we talked about.
Right, and we mentioned how mild atrophy causes pallor. The tissue fades to a pale color because the blood vessels are shrinking.
But at a score of 1, the color change is deeply alarming.
It is. At a score of 1, the tissue often becomes completely transparent.
Like you can see through it.
Yeah, the cellular layers are so degraded that you can almost see through them. Or, paradoxically, the tissue appears violently inflamed and bright red.
Because it is totally raw.
Exactly. Because that protective epithelial layer is totally gone, the raw underlying connective tissue is exposed to the environment, resulting in chronic, severe inflammation.
Which brings us back to that parameter on the visual index, the epithelial integrity. And specifically, there's a clinical term called friability.
Yes, friability.
If you are tracking the severity of this condition, friability seems to be the ultimate red flag.
It is. Friability measures how easily the tissue disintegrates and bleeds. In a mild state of atrophy, the tissue might bleed if the clinician gently scrapes it with an instrument.
And in moderate atrophy.
It takes only the light sweep of a cotton swab to induce bleeding.
And what defines severe friability, like a score of 1?
Severe erosion is defined by the presence of petechiae. Yeah, these are tiny pinpoint hemorrhages, little dots of bleeding just beneath the surface. In a patient with severe atrophy, these petechiae exist before the clinician even touches the tissue.
So it is bleeding on its own.
Right. The environment is so degraded that the microblood vessels are rupturing on their own, and the absolute second the tissue is touched, even with the lightest possible pressure, it bleeds immediately.
It is incredibly difficult to even conceptualize that level of fragility. I mean, the tissue is practically dissolving.
It is?
And it is not just the surface layer failing, right? The entire structural cavity literally begins to collapse in on itself.
Yeah, the total loss of estrogen starves the deeper tissues of collagen and elastin fibers. This triggers introital stenosis.
Which is what exactly?
That is the physical shortening and extreme narrowing of the vaginal canal. The muscles and connective tissue lose all their tone. Furthermore, the fornices, which are the deeper pockets of space at the top of the vagina around the cervix, they can become completely obliterated.
Wait, if the space is obliterated, where does the cervix go?
The surrounding tissue literally shrinks and flattens out, making the cervix sit completely flush with the top of the vaginal vault. The anatomical space simply ceases to exist.
That is structural collapse on a massive scale.
And the final, most severe sign of end-stage erosion is the spontaneous development of ulcerations and fissures.
You mean it just cracks?
Yes. The transparent, fragile tissue literally cracks open into superficial wounds just from the friction of daily movement.
So to summarize the internal damage here, a visual score of 1 is a smooth, transparent, highly narrowed canal that has lost all its folds.
Right.
It is covered in spontaneous pinpoint hemorrhages and open fissures, and it bleeds instantly upon contact. That is a profound physical trauma.
It really is.
But what is truly shocking in these clinical guidelines is that this structural collapse cannot be contained. It spreads outward, fundamentally altering the patient's external genitalia.
Right. And if we connect this to the bigger picture, That outward spread is exactly why the medical community shifted to calling it genitourinary syndrome of menopause. It encompasses the entire region.
It is not just internal.
No. To measure the external devastation, clinicians utilize a separate external vulvar index.
I have that index right here, actually. It evaluates the outer structures, so the labia, the urethra, the clitoris, and the introitus, which is the physical opening.
And it's important to note that unlike the internal index, a higher score here means greater damage.
Okay, so if the total score climbs over 8, or if a clinician records a score of 3 in any single external category, the patient is diagnosed with severe vulvar atrophy.
And the anatomical changes required to score 3 in those categories are severe. One of the most prominent external signs is profound lipodystrophy.
Let's define that for a second. Lipodystrophy means the complete degradation and loss of fat tissue, right?
Yes, the protective fat pads inside the labia majora, so the outer lips of the vulva, they completely dissolve.
Just dissolve.
Yeah, the outer lips essentially deflate and flatten out. And because the outer architecture retracts, the inner lips, the labia minora, are left completely exposed and unnaturally prominent.
Which just sounds painful.
It is, but in severe cases, the lack of estrogen causes something much worse. Agglutination.
Agglutination is tissue fusion, right? Meaning the inner lips literally heal themselves together.
They do. Because the skin of the labia minora becomes so incredibly thin, inflamed, and raw, the body's natural immune system just treats it like an open wound.
Oh, wow.
So the inflammatory response kicks in, causing the raw tissues of the inner lips to physically stick, scar, and fuse together right over the vaginal opening.
That is just horrifying.
We also see drastic changes to the clitoris. As the surrounding tissue loses its elasticity and shrinks, the clitoris begins to recede. In end-stage atrophy, it retracts until it is completely flush with the surrounding skin, entirely buried under the prepuce.
It is a complete architectural retraction of the external body, and we cannot ignore the urinary system here because this estrogen drought impacts absolutely everything in its path.
Yeah, if you look at the anatomy, the biological supply chain of estrogen receptors doesn't stop at the reproductive organs. Those receptors thickly line the urethra, the trigone, and the base of the bladder too.
So when those urinary tissues are starved of estrogen, they undergo the exact same thinning and loss of elasticity.
Precisely, which explains the urinary symptoms. The urethral tissue becomes so weak that the physical closure pressure of the urethra actually drops. The valve can't stay fully shut.
Meaning you can't hold it.
Right. This leads to constant urinary urgency, frequency, and leaves the door wide open for recurrent, painful urinary tract infections, mostly because that acidic bacterial shield is gone.
The sources mention a very specific structural failure here called a urethral caruncle. What physically happens to create that?
A urethral caruncle is a direct result of the structural support giving out. Under severe estrogen deprivation, the distal urethral mucosa, which is the very inner lining of the urethra near the exit, loses its connective support and actually prolapses.
It prolapses outward.
Yeah, it slips outward and exposes the inner lining to the outside. It presents to a clinician as a dark red, highly vascular, fleshy outgrowth sitting right at the urethral opening.
And the guidelines say these fleshy outgrowths can get up to 1 to 2 centimeters in diameter.
Huge, right? And because they are composed of delicate, exposed inner mucosa, they are incredibly prone to bleeding and make the simple act of urination agonizing.
Okay, reading through all of these diagnostic markers brought up a massive, highly practical question for me.
Oh, I bet I know what it is.
Well, think about the physical reality of a patient with a visual index score of 1. Their internal tissue is covered in pinpoint hemorrhages and bleeds before you even touch it.
Right.
Their external vulvar tissue might be partially fused, highly inflamed, and they might have a prolapsed, bleeding urethra.
Yeah.
How on earth does a clinician actually perform these objective tests? Like, how do you insert a hard plastic or metal speculum to check the pH, or aggressively swab the upper wall for cellular ratios without causing the patient excruciating, unbearable pain?
You have hit on the central critical paradox of treating this syndrome. The clinician absolutely needs to physically examine the tissue to objectively grade the severity of the erosion. But the severity of the erosion makes the standard examination physically impossible.
It seems like a catch-22.
It is. The clinical guidelines are explicit about this. In cases of advanced atrophy, attempting to use a standard adult speculum is considered completely out of the question. It will instantly tear the inelastic tissue, cause severe bleeding, and inflict immense trauma.
So what is the actual clinical protocol then? How do you gather objective data on a patient whose tissue is disintegrating?
Clinicians have to heavily modify their approach. They often resort to using the absolute narrowest pediatric speculums available in the clinic.
Pediatric speculums. Wow.
Furthermore, they have to use abundant amounts of external lubrication just to begin the exam.
But wait, don't the guidelines say you are supposed to avoid lubrication when doing a pH test or a cellular swab because it can alter the chemical result?
They do. In a perfect world, you want a totally dry swab. But in severe atrophy, the clinical protocol dictates that patient comfort and preventing further tissue tearing must override perfect testing conditions.
That makes sense.
And even with pediatric instruments and heavy lubrication, the pain can still be too immense.
Actually, the sources outline a pain management protocol that really highlights how severe this is. If the patient cannot tolerate the exam, clinicians are instructed to apply a 4% aqueous lidocaine gel directly to the raw tissue.
And then they must wait a full 10 minutes for the numbing agent to take effect.
10 minutes of clinical numbing just to be able to insert a tiny cotton Q-tip to check the pH of the fluid.
That is the reality.
Yeah.
Just to get a swab in to look for those immature parabasal cells. And we really have to acknowledge that sometimes, even with pediatric instruments, maximum lubrication, and topical lidocaine, a full internal visual exam is simply impossible.
The canal is just too compromised.
The physical canal is too narrowed and too raw. In those cases, the doctor must make the diagnosis based entirely on the external vulvar destruction, whatever minimal Q-tip swab they can manage at the opening, and the patient's reported symptoms.
So what does this all mean? We started this deep dive looking for the absolute objective line where getting older crosses into severe tissue erosion.
Right, and it is a massive shift.
It is. The biological journey we've traced is profound. It all starts when the estrogen foreman leaves the factory, and that single disruption starves the protective bacteria, destroys the acidic pH shield, and halts all cellular maturation.
And that invisible microscopic halt cascades into a massive measurable structural collapse. The elastic accordion folds go entirely flat, the deep collagen dies off, causing the tissue to physically shrink and obliterate anatomical spaces.
And the lining turns transparent, becoming so intensely friable that it spontaneously bleeds and cracks into open fissures.
Not to mention the external fat pads dissolve, the inner labia fuse together, and the inner lining of the urethra prolapses outward.
It is a highly specific, physically devastating chain of events. It paints a picture that is just galaxies away from, just a little vaginal dryness.
Absolutely.
This is a profoundly physical, strictly measurable, structural failure of the human body. It is not in a patient's head, it is not a psychological hurdle to overcome, and it is absolutely not something anyone should be expected to silently endure as a normal part of aging.
The fact that it is a strictly measurable failure of structural integrity is exactly what makes diagnosing it so critical, which honestly brings up an area of ongoing diagnostic research that I find incredibly promising, especially given the paradox we just discussed.
Oh, if it involves getting away from pediatric speculums and 10 minutes of lidocaine, I am all ears.
The clinical question researchers are asking right now is, if it is so traumatic and invasive to prove severe dryness using swabs on ulcerated bleeding tissue, how can we objectively catch this structural drought much earlier with zero pain?
That is the holy grail of diagnosing this.
It really is. So researchers have begun testing a diagnostic tool called a modified Schirmer test.
Wait, I know the Schumer test. Isn't like the little strip of calibrated filter paper that eye doctors hook inside your lower eyelid to measure if your tear ducts are producing enough moisture?
That is exactly what it is. Gynecological researchers are borrowing that exact same simple, painless paper strip and applying it to measure vaginal moisture.
You're kidding.
Nope. A clinician simply places the calibrated strip against the outer tissue for a set amount of time. No invasive speculum required, no scraping, no trauma.
They just put it there.
Yeah, they then literally just look at the paper to see exactly how many millimeters the moisture has traveled up the strip.
That is brilliantly simple. It entirely removes the physical trauma and the subjective guesswork from the equation.
It does.
Mm.
Recent clinical studies from 2022 demonstrate that the moisture levels measured on the simple strip of paper correlate beautifully with the complex visual health index scores and the internal pH levels.
Wow.
It provides a strict, objective, millimeter by millimeter measurement of the tissue's hydration without causing a single micro tear in the compromised ecosystem.
Could a simple piece of calibrated filter paper be the future key to objectively diagnosing this silent condition? Imagine a clinical world where doctors can catch the cellular supply chain failing long before the protective bacteria die.
Before the tissue turns transparent.
Right, and years before the anatomy ever reaches the point of severe, irreversible structural fusion. That is definitely a future to ponder long after this deep dive ends. Until next time, keep asking the hard questions.